Hello everyone, this is Cha Orhalo speaking on behalf of the UP Med Class 91 webinar team. This is an initiative of the University of the Philippines Medical Alumni Society. The UP Med webinar series is held every first and last Wednesdays of the month from 12 noon to 1 p.m. Manila time. It delves on important current and emerging medical topics and is targeted for physicians, especially general practitioners, occupational and industrial health MDs, primary care physicians, family and community medicine physicians, and other health workers. Registration is free. This webinar runs on GoToWebinar. If you are encountering problems as you participate, please log out from the session and rejoin the meeting room using the link sent earlier to your emails or by entering the webinar ID 157-533-923. If you cannot rejoin the meeting room, kindly stream the session at livestream.upm.edu.ph or text your questions to 0915-905-0918. May we remind attendees that first, your mic should be mute for the rest of the meeting. Second, use the chat box mainly for your questions and comments. All questions on the topic should be addressed to our moderator, Dr. Joanie Tila Santos Ocampo of Makati Medical Center and Asian Hospital. If you're experiencing technical problems, please feel free to send a message through the chat box. The session will run for an hour with 30 minutes allotted for lecture, followed by a reaction and the question and answer portion. May we now call on our moderator, Dr. Joanie Ocampo.
Thank you, Charis. Our time now in Manila is 12:02 noon time, and I'm speaking from the video conferencing room of the UP Manila, Padre Faura Street, Ermita, Manila. Welcome to all our participants. We have 31 logged in to GoToWebinar and 4 through live streaming. We would like to thank today's webinar sponsor, MSD. Today's topic is cervical cancer prevention and treatment. The objectives of this webinar are: number 1, to review the burden of this disease in the country; 2, to review the course of this disease and see where preventive measures are most effective; number 3, to emphasize the proper management of a cervical mass; number 4, to see the general rule in treating cervical cancer. Today's speaker is Dr. Glenn BENITEZ. Dr. BENITEZ is a graduate of the UP College of Medicine, class 1991. He then did his internship, OB/GYN residency, and gynae oncology fellowship training in UP PGH Medical Center. He has training on basic hysteroscopy, basic laparoscopy, advanced laparoscopy, and international laparoscopy. At present, Dr. BENITEZ is an associate active staff in obstetrics and gynecology at Makati Medical Center, a visiting consultant at Asian Hospital and Medical Center, consultant at Hospital ng Maynila Medical Center, medical director at Nationwide Health Systems Incorporated, and president of the Asian Gynecologic and Oncology Group, Inc. at Asian Cancer Institute, Asian Hospital Medical Center. Without further ado, may we call on my classmate, Dr. BENITEZ.
Thank you. Today's topic will be cervical cancer, the diagnosis, management, and we end with preventive concepts that are new and that we are applying in our country right now. The burden of cervical cancer, the overview. So we will talk first about cervical cancer. We will talk about the burden of the disease locally and globally, signs and symptoms, diagnosis, staging and treatment, and also I'll mention some things about the cost of treatment in our country, and also the survival rates, and also we'll talk about prevention, secondary prevention and primary prevention. The global disease burden of the disease in the world as of 2012, according to the WHO, is about 500,000 will annually develop it, and most of them, 85%, is estimated to come from the less developed world. Regarding mortality due to this disease, about more than half of those cases will probably die due to the disease. But interestingly, among the gynecologic cancers, this usually would be on the average in the younger age group at around the age of 45. In the Philippines, the burden of disease, as estimated in a 2010 Philippine Cancer Facts and Estimate by the Philippine Cancer Society, they estimate that cervical cancer, which is the second most common cancer in the country, will develop probably about, we will have about 4,800 cases, of which about 1,984 will eventually succumb to the disease. Another estimate for the Philippines is from a foreign study that said about 6,670 new cervical cancer cases will be diagnosed, and about more than half will probably succumb due to the late stage of the disease on diagnosis. Again, cervical cancer is the second most common female cancer after breast cancer, and it is the second most common female cancer among the younger age group, between 15 to 44 years of age. To compare with the data of incidences with our neighboring countries and also the world, you can see here that the annual number of new cases in the Philippines is 6,000, and in the entire Southeast Asia, we have about 50,000 new cases. Again, the world is estimated to have about over 500,000 new cases at that particular time. The age standardized ratio is about 16 per 100,000 in the Philippines, and that is comparable with our neighbors, which is estimated to be about 16.3. So we are pretty much developing it at the same rate as our neighbors. However, the world, the estimate is only about 14 per 100,000. So we could probably improve this data further. So the key point about cervical cancer in the Philippines, it is the second most common female cancer. About 12 Filipinas die of cervical cancer every day. Over half of the women with cervical cancer will die within the 5-year period from the time of detection and treatment. One interesting thing is that there was an estimate about the total number of women who have ever been screened in our country, and they say that there's only about 7 to 12% of women, the target group, that have ever been screened. So this is an area where we can really improve on. Now, talking about cervical cancer management. Usually, cervical cancer has no signs or symptoms in the early phase. Later on, when it's more widespread, it may present with pain, bleeding, discharge, smell, and usually there is a noticeable gross mass. I do want to emphasize at this time, especially for people who are doing screening in their clinics, I'd like to emphasize that never do a Pap smear on a cervical mass. We recommend that a cervical punch biopsy be done, and if this can't be done in your setting, it would be best to refer the case to a center that can handle the diagnosis. And if you do confirm with a punch biopsy a histologic diagnosis of cervical cancer, it would be best also to refer to a cancer center or a cancer unit near your place for staging and definitive treatment. The next slide shows the clinical staging. The first thing we do after confirming that there is indeed a cervical cancer, the next thing to do is to do staging. And here projected is the FIGO 209 staging, the latest staging for cervical cancer of the cervix. Do note that this is not a surgical pathologic staging. Unlike other gynecologic cancers that require surgery first before a staging can be done, cervical cancer still follows the clinical staging that we have been using from way back. And in particular, stage 1 is limited to the cancer is limited to the cervix. Stage 2 would be spread to the surrounding area. Stage 3 would be even further out to the pelvic side wall. And stage 4 would be distant metastasis with the different subdivisions here. We want to stage because it would tell us how to manage the case, but it also tells us about the 5-year survival rate. And as expected, the earlier the stage of the cancer, the smaller the tumor volume, the higher the 5-year survival rate. As it spreads further out, the survival rate drops further. Here is a graphic rendition of the cervical tumor as it spreads out. So you can see that the tumor starts spreading outwards. You also see that the stage starts going up, and that the 5-year survival rate for stage 1 in general is 85%. For stage 2, it's 65%. Stage 3 is lower at 35%. And stage 4 is 7%. Okay. So, next slide. Usually in the Philippines, unlike this drawing, in the Philippines, most of our cases are detected at stage 3. About 60% of our 60 to 70% of our patients referred at the PGH are already at stage 3. So treatment. After you do the histologic diagnosis and the staging, this will determine what treatment you can do. I do caution that surgery is only done for early stage small volume tumor, stage 1B to 2A1 at the maximum. You do not do surgery for the higher stage disease. The radical hysterectomy is usually not done by the general gynecologist, and that's why you must refer to a hospital with a gynecologist or a gyne cancer unit. I'll also just briefly show you later on mention some new surgical techniques that are done. But the gold standard of treatment for cervical cancer is still radiotherapy. Ever since the turn of the century, when radiotherapy was used for various cancers, cervical cancer has responded very well to radiotherapy. And it remains the gold standard up to today. It can be used in all stages, all ages, and all conditions. Even patients who cannot be cleared for operations can undergo radiotherapy. The current recommendation is that chemotherapy be added to radiotherapy as a weekly low-dose cisplatin infusion during the external beam radiotherapy. And this has improved the outcome of the treatment. And there are new techniques available, and we could probably say that it has improved quite a bit ever since chemoradiation became the mainstay of treatment. So most radiotherapy units would be found probably in the bigger general hospitals, private hospitals. And there's a few radiotherapy centers in the government hospitals. In the next slide, I'll be showing just a few drawings about radiotherapy, about hysterectomy, about total hysterectomy. As you can see, total hysterectomy hugs the cervix and the corpus of the uterus, leaving a substantial amount of the vaginal cuff. However, in the lower left part, a drawing of radical hysterectomy, We will take out the parametrial tissue, about 2 cms lateral to the cervix, and also about 1/2 to 1/3 of the upper vaginal area. The ovaries may be removed with the uterus, but it may be left behind in a younger age patient. This type of surgery is a bit more difficult to do, and it's best to refer the case to somebody who has training in this particular technique. This drawing just shows a schematic drawing of the removal of the parametrium and the upper vagina during a radical hysterectomy in comparison to a total hysterectomy. This is a specimen of radical hysterectomy, and you can see that there's more tissue on the peripheral margins, and can barely be seen, but there's also about a 1 to 2 cm cuff of the vagina here. Now, minimally invasive surgery is being done abroad, and locally we have colleagues who have been trained in minimally invasive radical hysterectomy, and we will be seeing more of these cases probably in the future. Abroad, they do robotic surgery, especially for gynecology cases, in terms of doing the ureteral removal, unroofing, and also the lymph node dissection. So, talking about chemoradiation, radiation has to be done together, the external beam radiotherapy and the brachytherapy. The external beam radiotherapy is usually done 28 days, so that's about a month. And during that time, you have to do weekly chemotherapy, about 5 to 6 sessions of infusing cisplatin during the time of external beam radiotherapy. The new machines that are being used now are linear accelerators that have IMRT or 3D conformal radiotherapy. These are softwares that allow a more collimated projection of the radiotherapy beam. And the newest one in the country right now, I think there's 2 hospitals that have it already. It's called tomotherapy, which even has more accurate definition of the tumor and the projection of the radiotherapy beam onto the tumor, thereby decreasing the exposure of normal tissues and decreasing the side effects of radiotherapy. But importantly, you have to do brachytherapy in these cases also. We have low-dose brachytherapy in PGH, and we have high-dose brachytherapy being done in other hospitals. Usually, brachytherapy high-dose is done weekly. The new thing that we have right now is that we have noticed that there is an improvement in the outcome with the entire duration of the chemoradiation to 56 days. So this is a drawing of radiotherapy. This is a linear accelerator machine, and the equipment, the head of the machine. And the head of the machine rotates around the patient, exposing 4 ports. So the next picture shows a drawing of brachytherapy, where in a machine that is computer controlled, and it allows the physician to place the Fletcher Sweet applicator, that's one example, into the uterus and onto the cervical mass. and leave the room, and after that the machine automatically places the radioactive source. Thereby, we have a chance to optimize the placement of the applicator at the best possible position, and then radiate the patient afterwards. So this is one of our patients undergoing chemotherapy. And the new machine that we have is called the tomotherapy machine. It looks like a CT scan, but that machine allows radiation in a collimated way, 360 degrees, thereby decreasing the exposure of normal tissues to radiation, but increasing the accuracy of placement of the radiotherapy beams. Now, talking about the cost, the treatment for cervical cancer, surgical treatment, is very expensive, and this is a table that was presented in our 208 postgrad lecture. So this is more expensive now. And radiotherapy in various hospitals would cost in the vicinity of about 93,000 to as high as 265,000 pesos for the linear accelerator and brachytherapy. So the total treatment cost, the range would be, just for the diagnosis and evaluation, would be already 15 to 48,000. For surgery, it would be about 50,000 to over 200,000 pesos. And chemoradiation would be 93,000 to 265,000 pesos. So to summarize the first part of my lecture, to treat cervical cancer, you have to do a punch biopsy. Do not do a Pap smear on a mass, and that gives us the histologic diagnosis. And then after that, the case should be referred to a gynecologist who can do clinical staging, which will determine treatment. And as I said, the gold standard is chemoradiation. Lastly, it is expensive to treat, and the outcome is poor, because the majority of our cases still come in at stage 3. And I do note that there are only few cancer centers with gyne-oncology sections in the country. So what do we do in these cases? And this leads me to the next part of the lecture. We should push for prevention. The knowledge of cervical cancer in the past 20 years has increased significantly. The carcinogenesis and progression of the disease is now well known. And because we know it, we can implement some preventive strategies that would allow us to decrease the incidence of new cases and let us capture it when it is most treatable, the pre-cancer phase. So secondary prevention is geared towards catching it at the pre-cancer phase or the CIN phase. The primary prevention is meant to handle the patient during when the patient still has normal cells. So this will be done with vaccination and other techniques. So risk factors, let's talk about this. To prevent cervical cancer, you want to remove the factors that sort of promotes development of cervical cancer, and that would be immunosuppression, like with patients with HIV, or cases with already CIN 2 or 3. That's also bad risk factors. Patients who have no screening, those who've had any types of HPV infection, 6 or more lifetime sexual partner, those socioeconomic class, smoking, oral contraceptive use is a risk factor also, early sexual activity, high parity, sexually transmitted infections such as herpes virus or chlamydia, or those with immunosuppression medication, probably due to transplant. So human papilloma viruses, in general, we have about 170 types that affect humans, and there are 16 types that would be considered as high-risk HPV types. And I put in red the two HPV types that are the highest or the leading causes of cervical cancer, number 16 and HPV-18. The type 16, 18, 45, and 52 cause about 80 to 95% of ENT cancers, head and neck cancers, and about 70 to 90% of gynec cancers. According to Diane Harper, in her article in 2004, the causal role of high-risk HPV type, established due to many molecular, epidemiologic, virological, cytological, and histological studies, reveal the complexity of the disease, natural history, but it also shows that an odds ratio of greater than 150, which is very high for case control studies. I believe smoking and lung cancer, the odds ratio for developing lung cancer is only 40. So it's quite significant if you have a persistent high-risk HPV type. Globally, it is estimated that the large majority of HPV-induced cancers lead to cervical cancer. But it also can cause other types of cancer in the anal area, vaginal vulvar, penile area, the mouth, and throat. We now know that the viral genome of HPV-16 and 18 and the other high-risk types. And we now know that the portion, the gene that codes for E6, early 6 and early 7, are the oncogenic genes that lead to cervical cancer. The E6 protein degrades the P53 oncogene suppressor, which prevents apoptosis. So now the cells cannot be destroyed. On top of that, the E7 protein blocks the retinoblastoma protein gene, which starts the P2F transcription factor and starts the cell cycle towards cell division. So it's like an accelerator being stepped on, and you start the cell multiplication process forward. So this is a drawing about the progression of cervical disease after HPV infection. On the left side is normal epithelium with the HPV virus on top, and usually it enters via microabrasion and incorporates its DNA in the basal layer of the cells. After that, you would have HPV infection coilocytosis, or you could have CIN1 where you have these plastic cells at the bottom third of the epithelium. And after months and months, it's either going to regress or it's going to move forward. And this plastic cell now thickens to about halfway through the epithelium, and then that makes it CIN2. And then it can proceed forward to CIN3, the upper third to the full thickness of CIN3, which makes it carcinoma in situ. The farther along to the right you move, the less the chance that it would spontaneously regress back to normal. In the early phase, where it's ascus or LCL portion, there is a higher chance of regression back to normal, even without treatment. But as you move towards CIN2 or 3, the tendency is to move forward towards invasive carcinoma. But this takes an estimated time of about 10 to 20 years. In the general population of the US, it's estimated that 80% of women will be infected with HPV infection, but 70% will clear within a year by itself. In 2 years' time, 90% will clear. Of interest is the 10% that persists beyond 2 years. In general, 8% of all women will develop CIN, but the majority will spontaneously return to normal. We are interested in that less than 1% that become eventually invasive cancer after 20 years of persistent disease. So this is a triangle that you see a reverse triangle later on. So I want to caution lang that HPV infection per se is not automatically bad. It's the high-risk type that persists. That's the one that we want to monitor and catch. Because the persistent infection with the high-risk HPV types is the necessary cause for progression towards cervical cancer. This is a triangle that shows the estimated annual cervical cancer patients in the world. In the bottom part, over about 300 million people will get high-risk HPV in the world, but only 30% will develop CIN1 or 2. And 10 million will develop CIN3. And of that, 500,000 will lead to new cervical cancers. So you can see that HPV infection can lead to cervical cancer only in a small minority of cases. It's a rare outcome of HPV infection. So with that pyramid in mind, you saw that the large majority, the significant large majority, are all in the pre-cancer phase where they are detectable. Screening is very important to implement in our country. And the way we screen right now is either cytology or through molecular testing or by physical testing. For cytology, we do conventional Pap smear, which has moderate sensitivity but high specificity. I do want to mention one thing later on about liquid-based cytology, because recently was noted that it was just as accurate as conventional smear, but I do want to differentiate between the two types of liquid-based cytology. One brand is called SurePath and the other brand is called ThinPrep, and we will tackle that later. We do have molecular tests. We have the HPV hybrid capture 2 digene test and the genomic test for 16 and 18, but they're quite expensive. We do have E6, E7 protein tests, but they're again also very expensive. So for screening, it might be something that we have to study very well for a low-resource country like ours. Now, for physical screening of the cervix, we do have what we call visual inspection with acetic acid, or VIA, and also VILI, wherein we use Lubel's iodine, also known as Schiller's test long ago. Now, the effect of screening on cervical cancer. This is one slide that shows that in England, between 1971 to 1995, you do see the incidence rates of cervical cancer starts dropping after they implement a very strict nationwide recall system wherein they would aggressively screen women. And the CINs increased during that time as they increased coverage, but the cervical cancer, the actual disease, started dropping. So this is a disease that is very, very amenable to control and prevention by screening. And there are many studies like that that you will find. So now talking about Pap smear, which is cytology using conventional method. It's a time-tested test since the 1940s when Papa Nicolau made a report tying up histologic changes with cytologic abnormalities that he detected. We've been using it regularly. It's cheap, it's easy, it's acceptable to patients, it's easy to learn for the medical provider. But you need an organized program and progressive periodic rescreening of the patients. We are unable to achieve consistently high sensitivity and specificity in many settings in the country because this is resource intensive. It requires laboratory, consumable reagents, trained personnel, especially cytotechnologists, and good quality assurance, which is something that really we have to implement in the country. We also have a problem with the lack of laboratories out in the provinces, and they send the slides to Manila. So the turnaround time is quite slow, taking about a month. Thereby, delays are informing the patient, and sometimes the patient is unreachable already, especially out in the provinces. Again, the sensitivity is not that high, 20 to 25%, and specificity is quite good, at over 90%. I do want to mention that the biggest problem we have with Pap smear is Pap smear sampling error. 70% of errors is due to the time that you are sampling. You have either poor supplies, you're using dry cotton swab, or you're using expired fixatives, or the wrong spot is sampled. We do know now that there's a transformation zone that has to be sampled, and this is the drawing of the transformation zone. This is the area where there's a highest chance of having the neoplasia occur. And there's also poor patient selection. Either somebody had recent menstruation or coitus or abundant discharge, or poor technique, where we have air drying artifact occurring because it was not preserved immediately. So alternate screening, these are just going to be quick slides. The nice thing about it, you have immediate results, and there's minimal requirements to set it up. And there's some drawings, some photographs of services with the use of VIA and also lupus iodine. But the problem here is you need regular quality assurance and a standardized definition. And it has high sensitivity, but the specificity is not as high. This is just a couple of VIA images that will move forward. The one on the right is the one that will be referred for colposcopy. So sensitivity and specificity of this test. So it's quite low, specificity, but the sensitivity is quite high because you're picking everything up, including the non-malignant cases, the non-neoplastic cases. So what we look for now is something more accurate. There are also HPV testing kits. I just wanted to mention that they're quite expensive, about 3,000 for the hybrid capture 2 test and 8,000 pesos for the genomic tests. In the market, they have Care HPV tests and also Gene Expert tests. And they are of interest to me because they are for low resource sites. Get results in 2 hours, but still the price remains to be seen once it's available in the market. This is just a picture of liquid-based cytology because I did mention that I wanted to push for liquid-based cytology. It has increased sensitivity for problems such as CIN2 and 3. It has pretty high specificity and decreased unsatisfactory results. Testing is, you can do reflex tests for liquid-based cytology, and this is automated. Now, I mentioned that there was a recent study about 2009 which compared liquid-based cytology and Pap smear, conventional smear, and this indicated that the liquid-based cytology does not perform better compared to the conventional Pap smear. And a lot of HMOs now have disallowed the use of liquid-based cytology. But I do note that in the study, they only used one brand of liquid-based cytology called ThinPrep. But there are other studies that show that it is quite important to note which brand of liquid-based cytology you use, because in this study, for example, the conventional smear that was done was quite close to the outcome of the ThinPrep in terms of picking up high-grade squamous intraepithelial lesions. And the number of unsatisfactory was also quite high. in both conventional smear and thin film. But in SurePath, they had a higher pickup of abnormal cells and less unsatisfactory readings. So I think people have to review with their pathologist, if they have access to liquid-based cytology, what are the what machine that they use, and what's the sensitivity, specificity of those tests. So, as a last comment about screening, cervical cancer prevention is not about doing the best tests or the most expensive tests, but if you're out in the provinces, cervical cancer prevention is about doing the best test that you can do. That's quite important. So VIA and VILI is quite reasonable to offer. But do note that screening by itself is useless. You have to be able to have a referral center where you can send them for effective treatment. So screening recommendation, these are already available in various textbooks. When to start screening, we recommend that not earlier than 21 years of age, because it's so rare to have any person develop cervical cancer at a very young age. Approximately 3 years after onset of sexual maturity. When do you discontinue screening? Well, one, when you did a hysterectomy and there's no CIN in the history, you can stop Pap smears. Or what about those who had a history of CIN and underwent a hysterectomy and had no CIN on the final histopath? The recommendation is to continue screening the vaginal wall, but they didn't specify how long, except to have prolonged screening. How about women who have the cervix and the uterus in place? The recommendation now is at the age of 65 with an intact cervix, with a history of about 3 consecutive normal smears and no abnormal cytology in the past 10 years. You can stop screening for these women also. Or women with comorbid or life-threatening illness, they don't have to be screened anymore. Those who have history of had cervical cancer, DS exposure, or are immunocompromised, you should continue screening for the next 20 years. Now, for the average patient in the 20s, you should screen annually, and if you have 3 normals, you decrease it to every 2 to 3 years. Women who have been immunized against the HPV-16 and 18 should still continue on the same regimen as non-immunized women. We should also encourage women, even if they're not for Pap smear, to still come annually for other preventive tests. How about women for above 20s, 30 to 65? It's recommended that you do co-testing, which is a combination of cytology and HPV and DNA testing. This is quite accurate in determining if the patient has a high risk of developing cervical intraepithelial neoplasia. And those who have had negative results in both tests, you can stagger their screening no sooner than 3 to 5 years. Women who have regular testing, Pap smears, at the age of 30 to 65, you can probably safely decrease it to every 3 years once they have several negative annual Pap smears. So management reference says, I just want to throw this your way. There's the National Comprehensive Cancer Network, the ACOG, ASCCP, USPSTF. I won't get into that anymore because at the end of the day, these are a lot of different types of patients, pregnant, adolescents. They all end up basically going towards colposcopy if there's any high-grade lesions. And the goal of colposcopy is to rule out with high certainty that there is no invasion. If there's no invasion, you can excise with cold knife conization or LEEP, or even a total hysterectomy if they have a myoma or other benign pathologies, or ablation, cryotherapy, and electrosurgery. But I don't recommend ablative treatment as they might hide problems that were not detected initially. So I end with a few more slides on HPV vaccination. The natural infection does not allow enough antibodies to rise to the point that you can protect the patient. So they made 2 vaccines already. We call them the bivalent and quadrivalent vaccine. We've seen that they are safe, immunogenic, and effective in preventing persistent infection and CIN infection lesions. They have both been approved since 2006 in the USA, and it revolves around what we call the VLP, or the virus-like particle, forming the HPV capsid. It has no DNA of the HPV, but just the outer capsule. These are just a comparison of the bivalent and quadrivalent vaccine. They're both given about 0, 1, and 6 months for the bivalent, and 0, 2, and 6 months for the quadrivalent. So I did mention about the VLP already. This is an interesting slide about HPV 16 and 18 that causes about the majority of cancers, and it's felt that the bivalent vaccine will decrease cervical cancer by 70% based on this. There is cross-reactivity for 45 and 31 in the bivalent vaccine, so this might push it up to even as high as 80.3%. There is a non-valent vaccine that is being studied right now that might come around soon, and this has theoretically a possibility of 90% protection. So this is just a slide of the potential impact of the potential reduction of invasive cancer would be about 70%, of HSIL by 60%, and LSIL by 25%. So I did mention that the safety of the candidate vaccine showed no increase in adverse effects, and they were tolerated well. In terms of efficacy, in the 2 large randomized controlled trials of the patient, they had 100% conversion, and they sustained their effect for about 10 years, and they showed protection and decrease in persistent HPV and CINs. Lastly, 2 doses may suffice. There are various articles coming out now that after 2 doses, the response is sufficient already to prevent CIN lesions. So I end with this. The HPV vaccine represents a historic breakthrough in cervical cancer prevention. And this was mentioned in the Eugene in Cebu in 2006. So this is just a summary. Prevention is cheaper, but requires an organized national approach. It must be high quality and tied to treatment and monitoring. You can do VIA if Pap smears are not available, and vaccination should be done, particularly for school-aged children.
I think that ends Dr. Benitez's lecture. Thank you for that very insightful lecture, Dr. Benitez. Just for an update, as of this time, the GoToWebinar attendance is already 55, and on live stream we have 18 logged on. Again, we'd like to thank today's sponsor, MSD, and our media partners, the Philippine Daily Inquirer and the Filipino Doctor. Before we proceed to our Q&A portion, let's have one of our panelists give her reactions. May I introduce Dr. Angela Bandola, who is a clinical associate professor at the UPPGH Department of Obstetrics and Gynecology, section chief of the section of OBGYN Infectious Diseases at St. Luke's Medical Center, BGC, and director of Cohen's Lifestyle Center, Philippines. May we now call on Dr. Bandola.
Right. Good afternoon, everyone. I'm here to give a reaction on Dr. Benitez's talk, which was excellent and very comprehensive. It is appropriate timing since it's Cervical Cancer Awareness Month. So I'd like to put things in perspective and discuss what's going on in the Philippines and why we should be taking part in educating our patients and helping them with primary prevention of cervical cancer. Now, when we talk about primary prevention strategies, patient education, and health healthcare workers' education is very important, aside from condom use, and I'd like to focus on vaccination right now. Now, what's the incidence of HPV disease in the Philippines now? Cervical cancer, there are 6,000 new cases every year diagnosed, and genital warts, in a small study, there's a 4.8% prevalence rate between males and females now. So HPV vaccination, when we talk about what is the baseline knowledge and attitude of mothers, there was a small study done in 2006 where 14% of the mothers knew that there was actually a vaccine against HPV. 31.8% were aware that HPV, or the human papilloma virus, was the causative agent of cervical cancer. And there is very high willingness. Now, 74.5% of mothers were willing to vaccinate their adolescent children. However, despite being launched in 2006, we still haven't achieved very high coverage of the vaccine among the eligible population. To date, there are like less than 5% of those eligible have received a vaccine against HPV. Wonderful to note is that there was a community-based DOH vaccination program that was launched late 2015, where they would be vaccinating 9 to 10-year-old girls in 20 poorest provinces of the Philippines, and there are already around 275,000 doses that have been given to these girls. When we talk about is it even beneficial, or the cost-utility analysis, is it beneficial to give the vaccine compared to screening and doing the Pap smear? Now, they did a mathematical computation now with 80% coverage, meaning high VIA coverage, so among 35 to 45-year-olds, combining it with HPV vaccination, assuming that there is lifelong immunity, would lead to the best clinical benefit in a 60% reduction in cervical cancer cases and deaths. And as such, we need to make a very clear recommendation that HPV vaccination is beneficial to our patients. Look at this graph saying that if we just suggest in our clinics, if we just do just a suggestion, around 40% would go vaccinate during that day, go for vaccination that day. However, if we give a clear recommendation for vaccination, we increase the vaccination rate for that day to 88%. And what information do we need when we're going to be recommending HPV vaccination to our patients? As previously stated by Dr. BENITEZ, there are a lot of cancers associated with HPV: cervical, anal, vaginal, penile, vulvar, and oropharyngeal cancers. So 100% of cervical cancers are caused by HPV, and 88% of anal cancers. The vaccine is very efficacious. So we're looking at the efficacy of the quadrivalent HPV vaccine against CIN2, 3, or AIS, and we see very impressive rates of reduction in disease, 98% for HPV 16 and 18, and 100% for HPV-related CIN2 and 3. Now we go to genital warts. So like I previously mentioned, 4.8% prevalence rate of genital warts in the Philippines. You note in this graph that males have a higher prevalence rate, and there's a peak. It peaks twice. Once in the 25 to 34-year-old males, and then eventually at the 50-year-old, there's also an increase. Now we see on the right-hand side that there are a number of physicians that encounter these cases. So it's not solely seen by urologists or gynecologists. IDS and dermatologists are also primary healthcare providers that have the first encounter with genital warts. So why should we be concerned about genital warts? Because there is increasing evidence that having genital warts is associated with an increased risk for anal, penile cancer in men, anal, vulvar, vaginal, and cervical cancer in women. And as such, we really should be paying attention to genital warts as well. And the vaccine that prevents HPV 6 and 11 has shown that there is very high efficacy rate in terms of preventing genital warts and external genital lesions. Now, what can we tell our patients? We can tell them that there is long-term information, long-term data showing that once they followed up those women, those young adolescents who received the vaccine, we have safety data and efficacy data. And today, 10 years after the clinical trials, there are still no breakthrough cases in terms of CIN2, 3, and cervical cancer. So this vaccine continues to be generally safe and well tolerated 10 years following vaccination. Now we're at this point that we have real world information on the impact of cervical cancer or HPV vaccination. In Australia, note very impressive decline of genital warts among those females who were vaccinated less than 21 years old. So the quadrivalent HPV vaccine was introduced in 2007, and you can see that at 2014, there was a remarkable drop, 94% drop in the prevalence of HPV genital warts, no? For both women, and also there was note also of a decrease in men who had sex with men. Again, more information on real-world data. There was significantly lower vaccine type HPV prevalence seen comparing 2007 to 2010 to the pre-vaccine era to 2003 to 2006. This is in the US. There are fewer diagnoses of CIN2 and 3, so this is a positive development, even for those who just received one dose of the vaccine, as compared to those who were unvaccinated. And as such, we're expecting to see a very good change, a positive change in terms of the epidemiology of high-grade cervical lesions. So there would likely be a decrease in abnormal Pap, abnormal other treatment for cervical precancers. And so this is the information that we need to give to our patients and hope that we can do our part in terms of decreasing the incidence of cervical cancer in the Philippines. So in terms of safety, no safety issues up to January 2016. Thank you very much for my time.
I think we're ready for a few questions from the audience. Okay, for the first question from Dr. Christine Relosa Camara. What is brachytherapy? And yes, that's her question.
Okay, brachytherapy is using radiotherapy right at the site of the tumor. So the pictures I showed was about the linear accelerator, which we call it external beam radiotherapy because the source is outside the body. But for brachytherapy, we place it inside the body, well, not really inside the body, but right at the cervix. So there is an applicator that we use, and it's called the Fletcher suite, the one in my hospital. There's various types that they have. And the nice thing about it is a cold instrument. It's not hot at the time you're placing it. It's not radioactive. So we place it, and then we verify the proper placement, and we pack the vaginal area with a lot of vaginal packs to move the bladder and the rectum away from the source. And then we move out of the room, and a machine automatically pushes the source in and exposes the area for the required amount of time, and then withdraws it out. And then the entire contraption is removed from the vaginal area. The patient is anesthetized and asleep during the whole time.
I hope that answered your question, doctor. The next question is, can we give cervical cancer vaccine to those with no risk factors already, or should we screen first before giving the vaccine? That's from Dr. Catherine Haynes.
Thank you for your question, Dr. Haynes. The vaccine can be given is licensed to be given for 9 to 45 or 9 to 55-year-olds. If there's no need to do a screening prior to giving the vaccine, let me just check. There's no need to do the screening prior to giving the vaccine. Yes, those with known risk factors would highly benefit from this vaccine, but should not be just selective towards these people who are at high risk for getting HPV infection.
Okay, for the next question from Dr. Haynes. Using visual acetic acid, what stage of the cervical cancer can it detect?
Okay, regarding visual acetic acid, it is recommended to be used for normal cervices. So if there is a mass that is seen already, a biopsy should be done to determine if it is truly indeed cervical cancer. So it is for a normal looking cervix. It is used in low resource areas or for patients who go to local health centers in the Philippines where they don't have access probably to a big provincial hospital or a center for Pap smear. They can immediately do the visual acetic acid and give an immediate recommendation to the patient to go for further testing if necessary. So visual acetic acid is for screening and it is for normal looking services.
Follow-up question from Dr. Haynes. Should we encourage screening for HPV for males?
Unfortunately, there are no clinical tests to diagnose HPV in males. However, the quadrivalent vaccine has been licensed to be given to males 9 to 26 years old. So there is no clinical diagnostic test available. There's only for research purposes.
Okay, that has been very interesting. I'm afraid that would be the last question. And before I go to the summary, I would like to thank Dr. Bandola for her reaction. So I think from what we've heard, there's a significant disease burden of cervical cancer, both globally and locally. Fortunately, treatment has continued to improve. Presently, special surgical techniques can be done by a surgeon. Just be more comfortable. Thank you very much, team. Surgeons specializing on this type of technique. As for cost, there is a definite challenge posed to all of us in terms of early detection because of a big discrepancy between cost of prevention and treatment. Apart from the cost issue, prognosis differs significantly in terms of a good one when one can live a normal lifespan versus those who will have a very small chance of survival even post-treatment. When we talk about preventing, it also makes sense to know about the risk factors, which is topped by smoking, which with odd ratios even greater than that of associated with lung cancer. In studies done internationally, it's been proven that affordable, acceptable screening does dramatically decrease morbidity and mortality. There are updated guidelines for screening, and there are varied recommendations for different risk groups. All in all, screening plus a good referral system in tertiary institutions still would be the best combination for improving the outcome of cervical cancer in our country. And as for the vaccines, they are available, and it is important to realize that wild-type HPV infection do not protect totally from reinfection. Hence, the vaccine fills this gap in protecting both men, and we must be updated about them. After this session, an email containing a survey link will be sent to you. After answering the survey, your certificates will be sent to you. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials from this session. Special thanks once more to MSD for sponsoring today's webinar. Thanks for joining us. We hope to see you again in our upcoming webinar on June 8th, Wednesday. That's from 12 noon to 1 p.m. Manila time with speaker Dr. Cecilia Fallon. Please invite your colleagues to join this continuing monthly CME webinar series. All webinar schedules and resources will be posted at www.upm.edu.ph/UPMedWebinars. On behalf of UPCM Class 1991 and the UP Medical Alumni Society, We also thank our collaborator units, UP Manila Information Management Service, National Telehealth Center, UP College of Medicine Postgraduate Institute of Medicine and Medical Informatics Unit, VOST, ASCI, and Ms. Cherise Orhalo, our host. We would also like to thank the Philippine Daily Inquirer and the Filipino Doctor for their support as our media partners. This is again Dr. Joni Santos Ocampo, together with Dr. Glenn Benitez, Dr. Angela Bandola, and the UP Med webinar team, closing this session. We hope you have learned a lot from today's webinar. Join us again on June 8th, that's next week. Have a great week ahead.
Bali